back the survey findings so that we can continue the cycle. The virtual Community Advisory Group will have representatives from all of the focal point countries, and they will feedback about the project protocols and instruments and ensure wider community collaboration. We want them to advise about the impact of the research and feedback on our data analysis. With the organisational outreach, we have the Community Advisory Group go out and conduct seminars, workshops and one-to-one meetings with organisations in the focal point countries. And we want to include not just HIV organisations, but a wide variety. So those who provide support and advice, cultural organisations, football teams, those kind of things, churches, people that provide housing and legal advice, so that this is a really inclusive survey. And then with the community outreach, we'll partner with this, organisations that are doing existing health promotion work and piggyback the survey onto that. We aim to develop some posters and flyers.
President Clinton was named United Nations Special Envoy for Haiti in 2009 to assist the government and the people of Haiti as they build back better after a series of hurricanes battered the country in 2008. Today, the Clinton Foundation has staff and volunteers around the world working to improve lives through several initiatives, including the Clinton Health Access Initiatives, which is helping 4 million people living with HIV/AIDS access life-saving drugs. As many of you know, President Clinton is no newcomer to this conference. In fact, this is the 4th conference in a row, a relationship that began in Toronto in 2006. And President Clinton's commitment to HIV/AIDS and to this conference is something we can all admire and look up to. So please, ladies and gentlemen, join me in welcoming President Clinton.
Thank you for the introduction. I'd like to thank Dr. Hablir, the U.S. Chair of AIDS 2013, and Dr. Eli Katabira, thank you for your leadership as President of the International AIDS Society and the Chair here. I wish you and your successor well. If we believe there can be an AIDS-free generation, even if you define it in the narrowest possible terms, how can we achieve it? When the AIDS conference first took place in America 22 years ago, a passionate group of activists, community leaders, and researchers shouting "silence equals death" made the world listen. We then had the first ARV, the failed cancer drug called AZT. It was treating a grand total of 5,000 people, all in Europe and the United States, at prohibitively high cost. That's a long way from where we are today with 8 million people on treatment around the world and the ability to treat all the rest who need it. Back then, AIDS was the death sentence, and those of us who are old enough to have been fully grown men still have lots of painful memories of our friends who did not survive. Then we couldn't really imagine an end to the epidemic. Now all of you have created the possibility that we could have an AIDS-free generation. As Bill Gates said, we still have a good ways to go, but we have come a long way. Everything I say today comes from the perspective of the work my foundation has done in the last 10 years. Before the Global Fund was funded, before there was any PEPFAR, our job was to go around and raise money country by country to figure out how to cut costs and to provide a working delivery system that would save lives. Now think about the commitments made here and by people throughout the world to achieve universal access, to eliminate mother-to-child transmission, and to cut new infections in half by 2015. We can do that, but it won't be easy. Just last week, on my annual trip to Africa to look at our programs, I visited Uganda, Mozambique, South Africa, and Rwanda. I saw amazing progress. I saw leaders committed to offer treatment to anyone in need. I saw a willingness to completely eliminate mother-to-child transmission. And I met with program managers who don't know where the money will come from and aren't sure we yet have the systems to do that. To achieve universal access by 2015, we'll have to increase the number of new people on treatment by 30% a year. For example, in 2005, there were only 10,000 children on treatment in low-income countries. Thanks to many of you in this room, and a special thanks to Unitate for stepping into the gap. The global effort to accelerate pediatric treatment means there are 500,000 kids on treatment today. But to reach the goal, we'll have to have 1.5 million more. To eliminate mother-to-child transmission, we need to test and treat women earlier and keep them on the treatment longer throughout the entire period of breastfeeding, when many of them live miles and miles and miles from the place where they get their medicine today. To cut new investments in half, we'll have to heed Julio Montaner's years of pleas to implement treatment as prevention and implement combination prevention programs. Now, we can save a lot of lives if all this is done, but we're going to have to do it together, to do what works, to spend the money we do have with maximum impact, and to raise what we'll still need. It's worth remembering, and I don't think enough has been made of this, that of the $16.8 billion now being invested annually in this effort, for the first time in my memory anyway, more than half of it comes from the affected countries themselves. And one of the reasons universal access is achievable is we can do it for less money than previously thought. My foundation recently released the results of a costing study that we did with 5 African governments across more than 160 treatment facilities in Ethiopia, Malawi, Rwanda, Zambia, and South Africa. I thank the leaders of these countries and all the healthcare personnel for taking the epidemic seriously and for the progress they've already made in scaling up the programs. The study was the largest of its kind. It shows that with the exception of South Africa, where labor and lab costs are higher, treatment costs an average of just $200 per patient per year. That includes the cost of drugs, diagnostic tests, personnel, and outpatient costs. There is no excuse for failing to provide treatment to the remaining 10 million people in need. South Africa, there are real opportunities with the commitments the government has already made. Our foundation recently redid the drug tender for them, and last year and this year, in just 2 years, they saved $700 million on what they were spending for drugs, and immediately added 340,000 people to the treatment road. More savings are on the way. Tenofavir's price has dropped 70% since 2008, 30% since last year. It's $125 now, and it's a good drug. The savings of that drug alone by 2015 will be $500 million. We can use that money in this fight. I have to be fully candid that meeting the goals of treatment by 2015 will require some activities, especially community programs, that weren't involved in the study. You've got to have community outreach workers if you want to get mother-to-child transmission down to zero. You just have to do it. You can't do it without it. But clearly, just what I've already said should convince you that we can meet the treatment goal. And we should. We also know that smart investments save money. The United States Center for Disease Control presented an economic model this week suggesting that implementing a test and treat strategy for key populations like pregnant women and people with TB and accelerating the scale up for others will not only save lives and avert new infections, it will actually lower costs within just 5 years. Where will we find the money? We all know that last December the Global Fund had to postpone the funding round because it was short on cash. But the fund is now back in business because the Gates Foundation, Japan, and Saudi Arabia stepped up on the heels of President Obama fulfilling America's 3-year commitment. Secretary Clinton recently announced here more money for the U.S. to meet the 2015 goals. And I'm hopeful that other donors will do the same, especially big countries that are growing fast, like China and Brazil. And don't forget, as Elton John's presence here and Bill Gates' presence here reminds us, there's an enormous amount of private money being raised and spent, and there will be more. From the Gates Foundation, Elma, Elton John, AIDS Life in Vienna, the Dutch Postcode Lottery, MacAid, SAN, many others. And governments, even in this difficult time, I believe will do more if we prove we're maximizing the impact of the money they have given us. The United Kingdom has followed a strict austerity program without cutting its development assistance. An astonishing fact. Our foundation works with them, with the Irish, the Norwegians, the Swedes, the government of Australia, all of whom are giving and giving, even in this difficult time. And finally, we need to make something good out of what is otherwise a not particularly wholesome development, the growing inequality of income in wealthy countries. Thank God a lot of wealthy people want to give more and would give it to this cause if they knew what an enormous impact their dollars can have. Do not minimize the possibility that we will have more private giving as we make more progress and demonstrate it. I also think that we can learn a great deal from Unitate, which has led the way in creating a new revenue stream that has saved hundreds of thousands of lives, just in my experience, from what it's done in putting children's ARVs and second-line ARVs out there at more affordable prices, leveraging short-term investments for long-term gain. We need more innovative financing. The International Finance Facility for Immunizations may offer a good model for us. It raises money by issuing bonds in the capital markets, which are backed by long-term commitments from donors, so the donors can buy now, but pay later. Increasing aid flows over a 5 to 7 year period, and then paying them back over a 20-year period, as we all know now, at low interest. Applying this model to raise funds to implement accelerated treatment, combination prevention, would mean that infections and costs will be lower when the time comes to pay the money back. If we all keep producing results, I believe the money will be there. And I am committed to doing whatever I can to see that it does. We do have to prove over and over again that we're making the most of the money. We have managed to lower treatment costs at the facility level from what UNAIDS said in 2003 was about $1,000 a person a year to $200 today. And beyond that, further cost reductions are coming. Looking ahead, there's some other things that I think we should do. First, we can target the money we're spending more effectively, especially in prevention. UNAIDS recently reported that in 2 African countries where 30% of new infections were driven by high-risk populations, less than 1% of the prevention dollars were spent to reach those people most in need of services. We can do better than that. Last year, UNAIDS published an investment framework providing guidance on how to prioritize national strategies, to focus on the interventions that have greatest impact. It's an excellent tool that I'd like to see more countries adopt. Secondly, and this may be somewhat controversial, but I feel strongly about it, we need a new level of openness about how every last dollar is spent by countries, by donors, by NGOs. You can't expect program managers all over the world to make the smartest decisions if they're trapped in a financial black box. All donors, all nations, all NGOs, I believe, should make our spending records open and available, not so somebody can be embarrassed, so we can see who's doing better and the rest of us can copy. We have to work together. If we do this, you know as well as I do, everybody's out there working, we can have a much bigger impact with the dollars that we have. Thirdly, I think we need investments based on evidence, not the politics and vested interests that too often drive spending decisions. To meet these goals, we're going to have the courage not only to start and scale up things we need to do, but to shut down programs that aren't working. And to channel more money toward the populations that are driving the epidemic and the evidence-based interventions that are working. And finally, we got to make sure that we're paying for services that directly help the people involved. When businesses start operations in new countries, they often send in their people, expatriates, to help get the work off the ground. But then management responsibility is transferred to national leadership. I think we reached a point in the HIV response where we have to do more of that, to transfer more responsibilities to national governments and to local NGOs. I don't want to imply that I think spending on international organizations can go to zero. That's just not true. Many countries still need support to grow and sustain their progress and to build the infrastructure necessary to run their own health programs effectively. But international technical assistance can be very expensive. Some organizations pay consultants up to $600 a day. For the cost of a day of consulting, we could put 3 people on treatment for a year. That is, I mean, every time we make the former rather than the latter choice, we have got to know what we're doing and be prepared to defend it in the light of day. Otherwise, we should go for the life-saving. Let me say that I think channeling more money to capable governments is catching on because it will save money and because it will build capacity and produce sustainable results in the countries that need them. PEPFAR has recently announced its intention to transition greater ownership over its funds to national governments. I am very grateful for that. And just last week, when I was in Rwanda, the national government and the health minister, I believe, is here today, announced a new effort to dramatically reduce overhead in training the entire healthcare workforce of the country. I applaud these efforts, and I think more of this can, should, and must be done.
The illustrator and the way that it was developed through the condom company. They developed it for female use, and one of the things, sometimes I get worked up, that we women are in need of is more female-initiated types of control about our safety, you know. And maybe they was coming from that point perspective, you know, initially when they did it, but you know, hey, just like if I see, you know, a tie that I like, and me being, you know, fashion savvy like I am, I might see that tie look better as a belt. You understand? So I may use a man's tie for a belt, whereas a man may use a female condom for anal sex. Okay. Any other questions? I thank you all. Thank you. I thank you all. Oh, one more? Where? Sure. Did I see it? Okay. Oh, don't be holding, God. Not necessary.
I wrote that piece because when in 1998, I was saving for 18 months at the time, and I went in to do my annual results, and I had worked in the field of HIV in 1993, and I was a pre and post-test counselor, and so I go into the doctor's office in 1998, and I look for the desk, and I
such a good time. Fell into it.
Oui, Afrique Mon Afrique, après dans le président Bill Clinton qui vient de clôturer cette cérémonie du sommet international sur le sida 2012. Le prochain rendez-vous est donné en Australie et ce sera avec la participation de tous. Nous vous remercions après une semaine, c'était dans la fin, ici au Convention Center. Nous avons vu défiler toutes les personnalités américaines ici pour soutenir et promouvoir le combat contre le sida. Nous avons vu tous les organismes internationaux qui nous ont représentés ici en Afrique. Nous avons vu la population sortie de tous les bords. 250 000 personnes étaient programmées ici et tous les pays ont répondu présents. C'était donc tout pour cette conférence 2012 sur le sida, rendez-vous en 2014 en Australie. Doudou Teklengoulé, comme d'habitude, votre servante auditrice. J'étais là pour vous servir. C'était tout pour ce soir, clôture de la conférence par l'ex-président américain, qui lui-même est fondateur d'une ONG qui défend les droits des sidéens et qui lutte contre le sida dans le monde et particulièrement en Afrique. Merci, c'était tout et restez connectés. Au revoir.
Born into this type of society, you have images from day one that tell you should love yourself. Whether it's through going to church or whether through is, you know, for me, my first time seeing a black gay man on TV with the gay living color skins, right? With, you guys know what I'm talking about. With menos for blah. So, you know, they're the comedic relief of the show. So that already gives you a self-esteem off the bat. And, you know, again, going to the black church and growing up and navigating high school.